right, so we left off last time. I believe I finished here, right? Any questions about obstruction before I move on? Because I feel like I kind of rushed through that last slide. All right, so let's go to GI bleeding. Now, GI bleeding, I put it at the end here because it really closely connects with liver disorders. So it's important not only to see the straight GI part of all of this, but how it connects to the liver and why bleeding occurs. So some of you, if you've been doing your adaptive quizzing, you may have seen this already, but I will explain that. So let's go first through the different types of GI bleeding. You can, of course, have GI bleeding anywhere in the GI tract, and we talked a bit about that already. Some of our slow bleeding with inflammatory diseases and stuff like that. But now we're talking about, some larger amounts of bleeding going on and why that might occur. So we can have upper GI bleeding. Upper GI bleeding refers to anywhere that's bleeding in the esophagus, stomach, or the first part of the small intestine, the duodenum. Often what you're going to see with upper GI bleeding is bright red blood, okay, because usually it's a fast bleed, and people, because blood is so irritating to the stomach, people will probably immediately start to vomit, so that blood is usually bright red, and then anything that's had a chance to sit in the stomach for any period of time will start to turn brown because of what the digestive enzymes do to the blood as it starts to try to process that blood. So that's when you see your coffee ground emesis is the reason why that occurs. The most common reason for upper GI bleeding is a condition called esophageal varices, and this is where the liver connection comes in. Esophageal varices are when the blood vessels around the esophagus in the upper part of the stomach, or the stomach, it's usually in the esophagus though, become dilated because of changes in blood flow through the GI tract, particularly in the liver. When the liver becomes fibrotic or cirrhotic, that decreases blood flow through the liver. And we'll go over the portal blood circulation system, but when you have problems in that system, again, blood will back up into the GI tract, particularly in these blood vessels. Now, there are other areas where you get varices, but the upper GI bleeding comes from rupture of the varices, or the dilated blood vessels around the esophagus. I will, again, explain this when we get into the liver and connect it back. So that's a really important connection that you need to understand. Other common GI bleeding sources include peptic ulcers. So that's a connection to peptic ulcer disease. So remember peptic ulcer disease? So ulcers in the stomach and the duodenum can start to bleed, cause upper GI bleeding. And something called a Mallory-Weiss tear, which occurs at the esophageal junction. And it's often related to severe or extreme retching and vomiting. So any population that you can think of that might be at risk, higher risk for Mallory-Weiss tear. Bulimics, right? Eating disorder, bulimics, where people force themselves to vomit to avoid absorbing calories. It can also occur for other, vomiting-related disorders, but that is a common population. So that, again, causes that tear to take place. When we tear tissue, we tear blood vessels, and blood vessels obviously will release blood. Lower GI bleeding occurs from anywhere from the jejunum to the rectum and usually comes out the other end. So some vocabulary to help describe it includes hematochezia, which means bright red bleeding from the rectum. Melena is when you guys are looking for dark stool, right? Now that you're assessing patients and so on. So melena is blood in the stool that turns the stool a dark color. They call it black stool, blackened stool. Okay, it does usually look, the blood turns to a black color because of the processing that takes place in the GI tract. You can also have occult bleeding. Does anyone know what that means?
Hidden blood?
Yeah, hidden blood. So it can be small enough amounts where you can't see it with your eyes, but how do we test for that? How do you test for that in clinical? I know we don't do it ourselves anymore. Yeah, now they have you send a sample of stool to the lab, but we used to have these little cards. We used to do it right at the bedside. I don't know, some places might still do it. We'd smear stool on it and use a developer to see if there was blood in that stool. Okay, so it can detect lower GI bleeding, slow bleeds, and so on. They also do occult bleeding testing at physicals. All right, they do that as part of a routine physical, depending on your practitioner, and then especially as you get older. Some reasons for lower GI bleeding. Remember we talked about polyps the other day? Those abnormal tissue formations in the GI tract that have a tendency to turn cancerous. They can bleed. And so that connection comes here, right? Polyps, colon cancer, checking for bleeding. So it's a screening procedure. That's really important to check for that bleeding. Diverticulitis, right? Remember diverticulitis? That's the inflammation of the diverticula. They can bleed. We definitely talked about it in relation to inflammatory bowel disease. Remember that? So which one? Which one do you see blood in the stool for more often? So we have ulcerative colitis and your Crohn's disease. Ulcerative colitis, right, is a typical symptom is bloody stool. Cancer, we just talked about. So cancers along the GI tract, cancer are very highly vascular. Tumors are highly vascular, right? Bleed easily. And hemorrhoids. Hemorrhoids are dilated vessels in the rectum. They often come from straining and age and so on, and they can bleed. So out of all of those, these are probably the least concerning, but they can interfere with stool flow if they get large enough and get in the way. So we do check for all of this stuff, and again, these can all cause lower GI bleeding. Any questions on that? Okay. So patho. The problem with bleeding and anywhere in the body, right? What is the main problem? Not looking even at this. What do we worry about when blood is not staying in the body? What are some of the things that concern you? Inflammation as a result. Yeah, so you can get massive inflammation, which can cause what condition? Sepsis can cause shock, right? That massive body-wide inflammation. All right, what else? What does blood do? Transports oxygen. So what are we worried about? Yeah, ischemia, tissue perfusion, right? So we're going back down to our basic concepts of the course. So tissue ischemia, which causes what? So cellular injury, right? Cellular death, and then we're in trouble, all right? So let's go through that. With that in mind, let's go through the patho of GI bleeding. So we get blood loss. We just said perfusion is an issue. Tissue perfusion, tissue injury, cell injury, the ability to make energy for the cells to function. When there's blood in the GI tract, the body tries to process it, which is not good either. We try to digest blood. That's not what our body expects to do. When we try to digest blood, we produce a lot of nitrogenous waste. And a reflection of nitrogenous waste in the body is BUN, right? So if we have a rapid rise in BUN, what does that become difficult for? Which system? The renal system. Yeah, the kidneys. It also will cause diarrhea, right? Blood in the GI tract will cause diarrhea, so you'll see diarrhea. What's the problem with diarrhea? Electrolyte loss. What else do we lose? Fluid loss. So we see volume depletion, right? So now we're losing water, we're losing blood from our blood vessels, so those are both volume depletion, right? Everyone following so far? Okay. Without blood in our blood vessels, we get decreased cardiac output, right? That's getting back now, and I know I said right at the top of blood loss, but here is where we're talking right about decreased perfusion to our body systems. So our body tries to compensate by increasing heart rate to circulate blood more quickly. You'll get hypotension, right, because we're losing blood. Then our body also tries to compensate by causing arterial constriction, blood vessel constriction, to raise the blood pressure back up. So you'll start to get a series of symptoms based on this compensatory response. So pallor, paleness, with blood loss and constriction of blood vessels. Decreased perfusion to kidneys and lots of waste in the body, right? We said that a minute ago. Decreased urine output and AKI, acute kidney injury. What kind is that now? Pre, intra, or post? Pre-renal AKI, intra, or post-renal? What do you think? Pre, right? Blood loss. We get decreased blood flow to the brain, decreased cerebral flow. So what are you looking at for symptoms?
Stroke.
Now, you could have a global hypoperfusion. You could have symptoms of stroke. What else? Dizziness from lack of blood pressure and lack of blood flow. Dizziness. What else? Are they going to make any sense? Confusion, disorientation. Good. Decreased coronary flow. Now we talked about cardiac output. That's cardiac output to pump blood to the body. Now we're here talking in the coronary arteries themselves, right? Lack of blood flow to the coronary arteries. So we talked about in the cardiac unit, if we have lack of blood flow in the coronary arteries, we're going to get ischemia to what? The heart. So symptoms of heart ischemia include angina, heart attack, heart failure, if the heart can't pump adequately because it doesn't have enough energy, and then fluid can back up and we can see pulmonary edema if it gets very severe. Because of changes in BUN levels, increased acid levels in the body, because we're trying to process the blood, you can see acidosis. And this really should be kind of its own bullet point here. Decreased mesenteric flow means decreased blood flow to the blood vessels of the GI tract. All right, so again, this is going back to decreased cardiac output, decreased perfusion to the bowel itself. So we said if we don't have enough blood flow, mesenteric again is the circulation to the GI tract, you can have tissue injury and tissue death. So you can see a bowel infarct. You can see part of your bowel die. And anoxia is lack of blood flow. So we talked about this already. But lack of blood flow to the central nervous system can cause you mental status changes. Okay? Any questions on that process? Does that make sense when we talk about reasoning and we connect it to different systems? And my flipped on Monday will try to get you guys to connect different disorders and different systems and so on. All right. I don't think I'd pay tons of attention to memorizing the visual here, but it's just showing you kind of different reasons for both bleeding and obstruction, all in one slide. All right, so now we'll move into the liver, which again will connect in some ways. It is part of the digestive system. Some will connect directly to disorders we've already talked about, and some will be new to you as well. So the first thing I like to do, as you guys know, is go through a brief A&P review. So we're talking here now about our liver, which lies in the right upper quadrant. Okay, so kind of to the other side of the stomach and connects directly to both the intestine, and you can see the pancreas over here, and then you have your gallbladder here. So they, again, work together in very important functions to make sure that we're getting what we need, so especially nutrients and so on, vitamins and nutrients. So we'll go through the liver, gallbladder, and pancreas. Obviously not all today, but those are the accessory organs. And we'll start with the liver. So as far as anatomy of the liver is made up of two lobes, right and left. Right is divided into caudate and quadrate. They're divided by the falciform ligament. And they're enclosed, the whole liver is enclosed by the glycan capsule. The glycan capsule is protective to the liver. It also contains the blood vessels, or some of the blood vessels, because the liver is very vascular. So it contains blood vessels, lymph vessels, and nerves. When there's a problem with the liver can enlarge and stretch the glycan capsule. And when you stretch the glycan capsule, that's where you're going to get your right upper quadrant pain from a liver problem. Okay, so that's very nerve-rich and can cause pain. Within the lobes of the liver are your liver lobules. They're just smaller anatomic units of the liver. Within the liver lobules are your hepatocytes, and those are the important little cells. Well, they're all important, but these are the functional cells of the liver. They're what doing there are what are doing the work of the liver. These cells are able to regenerate. We know, right, this is one of the organs in the body. You can lose up to 75% of your liver and regenerate that organ, so that's a good thing. And again, they do functional work. The sinusoids are small capillaries located in between the hepatocytes. They provide, obviously, blood flow. So really important. The Kupffer cells are your macrophages of the liver. So remember we said way back when that your macrophages are named different things all around the body. So we just did neuro, they're the microglia. So in here, they're the Kupffer cells. They do the same thing as a macrophage does. So they're looking out for pathogens, getting rid of things that don't belong there. And there's the disc space, which is between the sinusoids and the Kupffer cell, and the hepatocytes, excuse me. So it's just an anatomical area. This disc space helps to drain, so it has lymphatics, helps to drain excess fluid that we produce when we perform metabolic functions. Helps to drain it into the lymph system. And then the caniculus or the caniculi, which help to drain bile through the liver, which is an important function. So just showing you a picture here of a cross-section of one of the liver lobules with all your hepatocytes, your caniculi or bile ducts, your blood vessels, Kupffer cells, right, and showing you at a larger scale how these larger vessels, so remember we connect to our larger circulation, so our aorta branches into the hepatic artery to our liver, we drain blood through the portal vein to the venous circulation, and then the bile ducts, which are an important function of the liver. All right, so going a little bit further into our liver circulation, this is where we want to understand the portal circulation. So there's a little bit extra here that we don't normally talk about in our systems. We usually talk arterial and venous, right? So we're adding another view into another perspective here because it has that extra piece. So the simple part is we have the abdominal aorta, which I just mentioned a minute ago, that branches into the hepatic artery, which I won't be able to find on here because I'm looking for it. I don't think it is on there. So does everyone understand that? So we have the aorta branches off the left side of the heart, goes straight down the middle of your abdomen and branches to your organ systems. So to your liver is your hepatic artery, providing the liver with oxygenated blood. Then, of course, our blood passes through our organ systems and coming back from the venous system. Not only is the liver draining its own venous blood, but all the blood from the GI tract passes through the liver before it goes back into the venous circulation. So that's where your hepatic portal vein becomes important. Okay, so we have our mesenteric veins that are passing the blood, so all the venous circulation from the GI tract passing through the liver via the mesenteric and then hepatic portal vein. That circulation is really important because we draw from that portal circulation a lot of our vitamins, a lot of our nutrients that weren't drawn from the small intestine. Does that make sense? Those vitamins are very important for liver function, so that's why we need this portal circulation. So, and I believe I have an animation of this. It becomes really important to understand portal circulation when you're trying to understand your esophageal varices. Remember that from a little while ago? So when you have backup in that portal system, so the blood trying to come from the GI tract into the portal system through the liver, if that backs up, this is where the problem is taking place. So it backs up and dilates the veins around the esophagus, and they're prone to bursting. Does that make sense as far as circulation? So we're doing this in pieces. We're just talking about the circulation for now. Then we'll talk about why does that happen because of the liver problem. All right, any questions? All right, and then we also have the splenic vein coming from the spleen that empties into the circulation. And eventually, after going through that portal system, then it goes to the vena cava back to the heart. Does everyone see the difference between a regular system and this system? If you don't, ask questions. Yes?
So when it backs up, where does it back up to?
So remember where it comes from. It comes from the GI tract, right? So the esophagus, the intestines. So if it's backing up and then it comes to that portal vein, if it backs up from that portal vein, it goes back into that GI system. Does that make more sense? So the esophagus and the intestines. Okay, good. Other questions? All right, so here's the animation. So coming from the spleen, splenic vein, here's the GI tract, all right? So picture the esophagus, the intestinal venous system through the mesentery, coming up and through to the portal vein into the liver, through the liver to the vena cava. Does that help? Does the animation help a little for people who weren't totally clear? Yes?
Does the pancreas do anything with the blood or not?
The pancreas will absorb what it needs from the blood also, so oxygen, nutrients, and so on for the tissue. But you said the pancreas is more releasing enzymes into the GI tract, which we'll talk about too. So it's more the portal system into the liver that we focus on. Other questions? All right, so what does the liver do with all this blood and so on? Really important functions that affect the entire body. So that's why it's such a big problem when there's a problem with the liver. So the liver has important function of synthesizing, making, and storing amino acids or proteins, vitamins, and fats. All right, we absorb fat-soluble vitamins through the bile system that is involved with our liver function. We know already that detoxifies substances, right? We metabolize drugs, first of all, through the liver, and any toxic substances that come into the body. Do you remember what does that in the liver? From pharmacology way back at the beginning of the semester, last semester. You remember the P450, well, that's one of them. The enzyme systems lie in the liver to detoxify substances. So that connects to our pharmacology here. Provides blood circulation. Not only does it have important functions as absorption, as the portal circulation passes through the liver, it also filters the blood. Bile drainage takes place through the liver. And of course, we know that the liver is really important for storing glycogen and activating glycogen to regulate blood sugar. Or if you didn't know that, now you do. Okay? So here's a little bit more detail. So producing bile salts for that, for the fat-soluble vitamin absorption and fat absorption, really, both. Elimination of bilirubin, which is a byproduct of red blood cell destruction. So how long do red blood cells live?
120 days.
Yeah, about 120 days. So we have to get rid of them after that period of time. We replace them with new ones. So when we break them down, they produce levels of bilirubin that are cleared through the liver. Metabolism of steroid hormones, really important. So steroid hormones are your fat-soluble hormones. We said detoxification, metabolism of drugs. We talked about glycogen and blood sugar regulation, fat and protein, metabolism and synthesis, blood storage, blood filtration we talked about. Another important function is the synthesis of clotting factors. So our clotting factors, the ability of our blood to clot comes from liver function. Okay, they produce our clotting factors using vitamin K and stuff like that. And storage of vitamins and minerals. So lots of functions that if you throw off your liver, if your liver's not working, you can see a lot of things will be affected. Just another picture of not blood flow, but biliary formation and flow this time. which we'll talk more about when we talk about the gallbladder. But just showing you that the biliary system is important for processing bilirubin. If we can't process the bilirubin, it builds up in the body and causes a lot of problems. We'll talk more about that. And then lastly, for A&P review, I want to go more specifically over your LFTs, so liver function tests. We talked about several times this year, right? Last semester and this semester, we talk a lot about drugs and how we have to monitor LFTs because if the drug becomes toxic or a side effect, it can damage the liver and we'll see changes in the lab values. So the LFTs are on here, and then there are some other liver-specific labs that you would monitor. So antibodies comes along with infectious disorders of the liver. We can look, what kind of infectious, off the top of your head, what do you think of when you think of an infectious disorder of the liver? Hepatitis, right? Viral hepatitis. So we can look for antibodies for viral hepatitis, whether we're looking for them to see if someone's immune because they've gotten the vaccine, or we think someone's infected with the virus. ALK-Phos is one of your LFTs. It becomes elevated when you have things like biliary obstruction. So that, remember we said we have the biliary system in the liver where the bile passes through. If for some reason that's obstructed, we'll see elevations in ALK-Phos. Or other hepatocellular damage, liver damage, or cancer. AST, another, we've talked mainly about AST and ALT this year. So AST, ALT, and lactic dehydrogenase, LDH, is often included in the panel, are the LFTs. And they mainly increase when there's some form of hepatic injury or liver damage. So we test those routinely in someone who's ill. So pretty much anything that damages the liver, so including your viruses, including things we'll talk about later, can cause elevation. So remember, they go up when the liver is not functioning well. Serum bilirubin. We said bilirubin needs to be processed by the liver. If not, it builds up in the body. So if the liver is not functioning well, we can test for bilirubin levels to reflect the fact that the liver can't process. Albumin, we know. What do we think of albumin in relation to? What is it?
Well, season with blood buffers.
Yeah. So, yep. Oncotic pressure you're talking about. Good. What else? Did you say something different?
Protein binding.
Protein binding for what? Drug transport, right?
Yeah.
Drug transport, steroid hormone transport. So two really, actually perfect examples of why we need albumin. All right, albumin holds fluid in our blood vessels. Albumin transports drugs, drugs and hormones. And albumin is important for our nutritional status as well. So if that's not there, if that decreases, that will indicate that there's a problem with the liver. So we have so far increased is a problem, increase is a problem, decrease is a problem. What does transferrin remind you guys of? What is it?
Why?
Iron, ferrin, ferrous sulfate, right? Transferrin is decreased in liver damage. Transferrin reflects how well we're storing iron. Remember, we store iron, right? What do we need iron for? Blood formation, right? Red blood cell formation. So if that's low, the liver can't store it, then there may be a problem with the liver. Alpha-fetoprotein is fairly particular to cancer, liver cancer. It can indicate other cancers in the body as well, but if we're testing it in relation to the liver, it's often elevated if there's hepatocellular cancer. And then PT-PTT, what does that remind you of? Clotting time. So what are we talking about here? If we're testing, why are we testing PT-PTT in relation to liver damage? What is it?
Bleed risk.
Yep, so we're worried about bleeding, and why might that be off? The liver makes clotting factors. So what are you going to see? It's prolonged. Now I'm getting myself confused. So the time it takes for, this indicates the time it takes for the blood to clot. So will this go up or down? Up, right? So again, liver damage here. Any questions? Yes?
Well, what would the difference be between PT and PTT?
PT is more reflective of, remember we test this more with Coumadin, so the vitamin K probably levels, and then the PTT are more like factor 10 clotting factors. So, and I'm sure they do test for, so this one is testing for the clotting factors related to vitamin K. I'd have to double check what they exactly are, but just reflecting different clotting factors, okay? Other questions? All right, so the broad view then, the broad view of the body effects of liver failure or liver issues. It kind of takes everything we just talked about and put it together as to, so what, right? What are the problems? So liver failure goes into disorders of synthesis and storage functions, and we'll touch on all of these when we talk about the disorders, but this just puts it all in one place for you. So all the things that go wrong because of lack of synthesis and storage. So your lack of iron storage, lack of clotting factor storage, etc. And disorders of metabolic and excretory functions. So basically things building up in the body. And different problems with those substances in the body. All right, so just again, you don't have to memorize this, but it helps. If you're confused, it helps to give you a map of why and where it goes. Now, the next thing I want to talk about is some general manifestations of hepatocellular damage or failure. So coming right off of what are the problems, I want to talk about, again, what are some of the common issues you're going to see with any liver issue. And then we get into specific liver disorders. So these essentially apply to most, if not all, of the specific liver disorders that we will discuss. And you should understand they're important. So things like jaundice, portal hypertension and bleeding, which we've talked a little about already, so hopefully that the ideas are forming in your head already. Ascites, which we briefly mentioned a moment ago, vitamin and dietary deficiencies, regulatory imbalances, hepatic encephalopathy, and hepatorenal syndrome. So first we'll start with jaundice and why that could take place. Jaundice is also known as icterus. Now, most people say jaundice, but I actually have seen icterus written in a few charts in the past few years. So it's important to be familiar with the vocabulary. And what jaundice means is that there are high bilirubin levels in the body, or hyperbilirubinemia. Usually you'll see signs of jaundice when levels have gone above 2.5 milligrams per deciliter, normal being less than 1.2. And the reason for it is some problem with bilirubin metabolism, which we know, again, takes place in the liver, right? So just looping back to our anatomy and physiology. So some typical reasons, one unrelated to the liver itself, but just important for you to be aware of, is excessive hemolysis of red blood cells, or hemolytic anemia. This is a situation that takes place when, for some reason, red blood cells are being broken down very quickly. Does anyone know any situation where that might take place? All right. Well, sometimes a toxic exposure can cause that. A wrong blood transfusion can cause that. So someone gets the wrong blood type. I think I've told you I saw that in real life one time. It was very frightening. And sickle cell anemia is another case where that could take place. So what happens as these red blood cells are being destroyed, they release bilirubin. Normally, the liver processes it and excretes it, but because it's so much, it builds up in the system and causes hyperbilirubinemia. Then the one we're more focused on are the hepatic cellular failure. So as simple as saying, again, the liver is not processing the bilirubin because they're damaged. The liver cells are damaged, so they can't work. Cellular injury, lack of ATP production for some reason, or inflammation, and they can't process bilirubin. And then there's also a case, now remember, anatomically, bile will flow through the liver for processing. There are ducts, there are bile ducts right through the liver. If the bile ducts are obstructed for some reason, the bile can't go through, and again, it'll back up and build up in the body. So questions on that? Yes?
Why are some babies born jaundiced though?
Jaundice has to do, and I'm not maternity, but I had 2 kids, and both of them were jaundice. It has to do with, the exposure, I don't want to say the wrong thing. I believe it has to do with the exposure to maternal blood and post-birth processing of that. And then it has to do with temperature as well. So why don't I look that up so I don't tell you the wrong thing and get back to you on that, because I don't remember the exact patho of it. So where's my pen? So newborn jaundice you want to know about? And my nephew had enough jaundice that he had to go for blood work for like a month after he was born. So I'll look that up for you. So yeah, it's a problem with obviously bilirubin processing. And if anyone has more knowledge of that, please share. Because again, I've lost all my maternity knowledge over the past 20 years or so. Okay. Okay, so just showing you now what actually takes place with the mechanisms of jaundice. So we have on this side our obstructive types of jaundice, all right, and you don't have to memorize all of this. Basically what's happening here is because the body can't conjugate or process the bilirubin, it is not going into the stool where it normally goes, all right, we don't normally excrete it through the stool, and it goes into our bloodstream instead and deposits into tissues, and it goes somewhat into the urine instead. So it should come out through the stool, it's going into the bloodstream and tissues and into the urine instead. All right, so this just gives you more detail if you wanted to talk or to look at that more closely, but just remember what I said as well. So that brings us to our clinical manifestations. So bilirubin is a dark yellowish, brownish color. So if it starts getting into our urine, it will darken the urine. So what I learned in school is tea-colored urine. So darkened urine, not your yellow or clear. Light-colored stools. Again, it's a brownish, yellowish color, and it will darken stools when it is excreted appropriately. So without that in the stool, you may see light-colored, and they called it when I was in school clay-colored stool. So lighter colored stools. If it's an infectious process, so for example, hepatitis, it may be accompanied by fever and chills and pain because of enlargement of the liver. Excessive bilirubin can cause loss of appetite, fatigue, itching, because the bile salts are in the skin and they don't belong there, so it can cause inflammatory response, so people get real itchy. And then probably what you guys, or we as a group, would recognize most readily, yellow discoloration, not only of the sclera, but of the skin. Now, why might you need to look at the sclera instead of just the skin?
In your darker skin population,
Darker-
it's yellow.
Yeah, darker skin population, it's really difficult to see jaundice. So if you look at the sclera of the eyes, it's much easier to tell. All right, and as bilirubin builds up more, people will get more yellow. Okay, so I had a poor patient years ago when I was at Mount Auburn. He was just, he had everything liver related. He was like the case study of liver disease, but he was the most yellow color I think I've ever seen in my life because he had such severe jaundice. So it can be a little startling. Okay, so here's a yellow sclera for you. So can everyone see why that doesn't look like a normal sclera? And that's jaundice. Any questions on jaundice? Because I know these are little snippets. And how am I doing on time here? Okay. All right, let's go into portal hypertension. So I gave you a little introduction about it already. Portal hypertension, we know what hypertension is, right? We know hypertension is high pressure in a blood vessel. So in this case, we're talking about abnormally high blood pressures in our portal venous system. Venous systems are supposed to be low pressure systems, right, to begin with. So the vessels themselves are not as strong as arteries. So when we start increasing pressure in veins, then we get into a real problem because they're much more likely to rupture. Does that make sense? All right, so that's the problem. So abnormally high blood pressure in the portal venous system, above 10 millimeters of mercury. Normal is around 3, so very low pressure, right? Our normal arterial pressure is what? On the systolic phase, it's like 100 average, right? So very low pressure system. In contrast, reasons for portal hypertension is anything that doesn't allow blood to flow through the portal venous system. So that large portal vein comes in, branches through the liver for the portal circulation, and then comes back to the vena cava. So we're talking about within the liver. So some kind of obstruction, inflammation of the liver, with or without clots in that circulatory system. If you have clots or inflammation, what happens? So clots block blood flow, right? What about inflammation? What the heck does that have to do with the blood vessels? It's not in the blood vessels, right? It's in the tissue. So why is that a problem? Why is it causing obstruction? It squeezes them, yeah. It's squeezing the vessels. If the liver is all inflamed around the blood vessels, it's squeezing the blood vessels so that the portal vein can't get the blood into the liver. Good. Fibrosis, inflammation of the sinusoids, where our vessels flow through. So if the tissue around the vessels is becoming fibrotic, or scarred, or cirrhotic, the blood flow can't go. There's no elasticity to the tissue. The blood vessels cannot stretch. So therefore, it backs up into the portal system. In green, the most common cause of portal hypertension is cirrhosis of the liver. Viral hepatitis can cause portal hypertension. In viral hepatitis, you get massive inflammation, some forms of viral hepatitis, massive inflammation of the liver, squeezes the blood vessels. Schistosomiasis is a parasitic infection, not very common here. You'll see it in other countries. It can cause inflammation of the liver. Cardiac diseases, so relating to other systems, in right heart failure. So now we're going to a different point in the system, right? We're going even beyond. Where are we with right heart failure? Think about, how does the blood enter the heart from the right side? What vessel? The vena cava. In this case, we're talking about the inferior, correct. Inferior vena cava, if the blood's not getting through the heart because the right side of the heart isn't pumping efficiently, it's backing up through the liver into the portal system, right? Make sense? Yes?
Would that increase our risk for aortic aneurysms?
No, aortic aneurysm is usually on the left side of the heart. Yep, so that's more the high blood pressure on the left side, atherosclerosis, stuff like that. Okay, any questions on that? So now getting into our connection to what we talked about earlier. Portal hypertension, that high pressure in the veins, can cause varices. Varices are dilations of the vessels around the esophagus. As I said, there are other places in the GI tract that are dilated because of portal hypertension, but I focus on varices because that's what's going to cause your upper GI bleeding, which is very common in people with things like cirrhosis. Also enlargement of the spleen, because that can disrupt portal venous flow. Ascites can, backing up. Splenomegaly can result from portal hypertension because the portal system backs up into the spleen as well, so that will enlarge the spleen. Can cause ascites. So what is ascites? Collection of fluid in the abdomen. How the heck is that related? Now, we're not talking about protein here, because that's part of it. That's another etiology, but Why would you get ascites from portal hypertension? Blood vessels are real dilated. It leaks out, right? So it's a permeable membrane. The blood vessels are a permeable membrane. If they're under high amounts of pressure, they're going to say, we got to lower the pressure somehow. Starts releasing fluid into the abdomen. And because the portal venous system is important, passing that blood through the liver is important for detoxification. If the blood can't go through the liver, sometimes it will shunt around the liver, right, so it won't go through portal circulation, it won't get detoxified. So now we have these metabolites, these toxic substances, freely circulating instead of being detoxified and excreted. And we'll talk about hepatic encephalopathy separately, but if some of your toxic substances circulate to the brain tissue, it can cause encephalopathy or dementia related to liver disease. Does that make sense? So shunting around, not going through. So again, a place to look at it all together, not necessarily to memorize, but will help you figure out so what with portal hypertension. Now, the only thing that's not on here, which is concerning, is that esophageal varices and GI bleeding. So that's an important piece. Oh, maybe it is here and I just got ahead of myself. So varices, we get that prolonged. So we've talked about this a few times already, so we'll just kind of run through this quickly. Prolonged elevated pressure in the collateral veins, so the veins that are around the esophagus and other areas. So here they are. They're the lower esophagus, stomach, and rectum. Here's where I'm really worried about, although stomach too, because that can cause upper GI bleeding. So they're distended. They're dilated. Tortuous means they're kind of twisted, and they're collateral veins. They can rupture. So here, label this upper GI bleed, okay? Hematemesis is vomiting blood. Loss of blood can cause anemia. And we can have hemorrhage, which leads us again back to our upper GI bleed pathophysiology. Really dangerous situation. We can treat varices. However, they're not going to resolve. If you have permanent damage to the liver, remember cirrhosis is our most common cause of varices. Cirrhosis is irreversible, and again, we'll go over this when we talk about cirrhosis. We can treat them symptomatically, but we're not probably going to cure varices. So someone who has a rupture varice will most likely have another one at some time in the future. So our goal of treating is to stop the bleeding so that people don't die of hypovolemia. And we also want to prevent system damage from lack of perfusion. So we will give some medication. We can give medications to help. We can also replace blood. As far as treating the actual varices, you can use, they can inject them and sclerose them, so harden them so that they stop bleeding. So this is what this is showing here. And then what I saw more, because they only started doing this more recently, is we used to put a special NG tube. We'd drop a special NG tube that would treat the varices. So this NG tube is not like the ones you might have learned about in lab already, or maybe you did learn about this type of NG tube. It's called the Senstaken-Blakemore tube. It's got 3 ports. So you drop that into the stomach. It has a balloon, 2 balloons at the end of it. You can inflate them with air, and they will put pressure on the bleeding. So it's basic first aid here, right? You're putting pressure on bleeding. So that's what the balloons do. Obviously someone's NPO while we're doing this. And then you have a port to aspirate. So if you want to check if there's still bleeding going on down there, you can aspirate that. Or you can put it to suction, which you'll see more commonly, to get rid of whatever is sitting. Because remember, blood in the stomach is very nauseating and causes vomiting. Okay? Any questions on that? So as I said, this is a symptomatic treatment to stop the bleeding so that the person doesn't die of hypovolemia and lack of blood, but it will likely recur if it is a cirrhosis cause. All right. Hepatic encephalopathy. So we do circle around a lot with these disorders because, again, they are all related to each other. We just mentioned that quickly a minute ago. And it's related to the fact that the blood is not being detoxified through the liver because, again, a problem with the liver. It's also called portal systemic encephalopathy. Neurologic syndrome, again, because blood is being shunted around the liver rather than going through the liver for detoxification. So we think that when these toxins affect the neural tissue, they cause dysfunction in your cognition. Therefore, the characteristics are cognitive changes like impaired cerebral function, disorientation, memory changes. A classic symptom of hepatic encephalopathy is something called asterixis, which is a flapping tremor. So I would demonstrate, but I would look very foolish. But they do have, I believe, an illustration in your book. So it's a flapping tremor. People look like they're flapping their hands. Yes?
So is that permanent or can it be reversed after
If it's caught early, it can be like for a, where are we here? Acute fulminant hepatitis, which is rapidly developing viral hepatitis. If it's treated very rapidly, it probably will resolve. However, the slow developing with chronic liver disease, because that is irreversible, you may be able to treat it symptomatically, but probably not completely reversible. Does that make sense? Okay. So again, going back to that, let's go back up to symptoms. You will see EEG changes. Remember, that's the electrical activity of the central nervous system that indicates to us how the central nervous system is functioning. And then with slow development, it's often related to chronic liver diseases like cirrhosis, which is irreversible. Rapid development can come with acute fulminant hepatitis, which is rapidly developing viral hepatitis, which is relatively rare. That's a good thing. But we see it more with this chronic liver disease. I did leave this in. I meant to take this out, but it gives you more detail about the patho of hepatic encephalopathy. It gives you some fancy words in there that basically say the same thing I just said. The blood is not getting detoxified, the toxins are going to the brain and causing biochemical alterations and neurotransmitter changes. Those are things that help our central nervous system function normally to give us good cognition. Particularly, now we'll talk about that because that is important. Ammonia, so a lot of the toxins that circulate there are hazardous, but ammonia is the most hazardous that causes a lot of these central nervous system changes. We do produce ammonia in our body when we digest protein. And again, a lot of ammonia in the body will change our central nervous system function. Okay, questions on that? So clinical manifestations. Again, this is a little bit redundant because I meant to put it all on that one slide. Personality changes, memory loss, irritability, sleep disturbances, confusion, that flapping tremor, supraconvulsions, coma, and death. Symptoms are often related to levels of ammonia, so the severity of symptoms relate to the levels of ammonia in the body. And we can treat hepatic encephalopathy with a drug called lactulose, which I don't believe I had to do a drug care map on. So we'll just go over it here. Now remember, I think there was a little confusion last semester. Even if you don't have to do a drug care map, you still have to know the drug. All right, so the difference is I just give you the information I want you to know rather than having you go through the whole profile for the drug class. All right, so lactulose is a drug that helps reduce ammonia levels. It's also used as a laxative. Bless you. How it does this is it absorbs the ammonia into the GI tract, back into the GI tract from the bloodstream. It also has an osmotic effect, so it absorbs a lot of water back into the GI tract as well. So therefore, it does cause some pretty significant diarrhea. So that's fine if you're using it as a laxative, but your liver patients, many of which I have taken care of, do not enjoy this large amount of diarrhea they have because of the drug we're using to treat their ammonia levels. So this does require some nursing intervention, teaching, education. And then we said the therapeutic effect is diarrhea, but to decrease the ammonia levels, to excrete ammonia through the GI tract. So that's the therapeutic effect. However, as the nurse then, what are you going to monitor? Aside from the education that I just told you about with the patient, what are your concerns because of the effect of this particular drug? What do you want to look at?
Electrolytes.
Yeah, electrolytes. Which ones do we lose through the GI tract mostly? Potassium's a big one. Sodium. Okay, good. So we want to watch our electrolytes. What else? We can look at the stool. We want to track INO, but we also want to look at things that might indicate dehydration, right? So what kind of things?
Skin turner.
Yep, you can look at skin turgor. You can look at your vital signs. What are signs that you're becoming dehydrated? Vital signs. Low blood pressure, increased heart rate, right? And then, how are we monitoring the therapeutic effect? What can we look at for that? What are we trying to decrease? Ammonia levels. Can we measure ammonia levels?
Yeah.
Yeah. So we want to watch our ammonia levels, right? Make sure that it's actually working. Good. Questions so far? All right, ascites then. Going on to ascites. We know what ascites is. We said earlier that's accumulation of fluid in the peritoneal cavity, and this year we've talked about several reasons that someone might have ascites. So one of those reasons includes a liver disorder. We said already that it can be caused by increased pressure in the mesenteric tributaries of the portal vein, or what condition is that describing? Lots of fancy words there. What is that condition called? We just talked about it. Increased pressure in the mesenteric tributaries of the mesenteric portal hypertension, right? So right portal hypertension over there. The hydrostatic pressure. What's the hydrostatic pressure? Of what? Water.
Into the interstitial space.
Yes. From where?
In this case, the liver.
Blood vessels, right? So the water in the blood vessels that are all dilated is pushing on the vessel wall, has nowhere to go, so it leaks out, right? That's, I think osmosis. My son's learning this in science right now, so I'm relearning it all myself. So osmosis or diffusion, one or the other, wants to equalize on both sides of a membrane, right? So it goes into the interstitial space or into the peritoneal cavity and causes distension of the abdomen. So we talked about why that occurs. Not on here. What else causes ascites in liver disease? Go back to your A and P, your physiology. What does the liver do? Produces something that is important for fluid balance in and outside of the vessels. Starts with an A. Albumin, right? So if our liver is not producing the albumin, it's not circulating in our bloodstream. We said albumin exerts what kind of pressure? Oncotic pressure that holds fluid in. So we have a double whammy here. We have the fact that we have increased hydrostatic pressure pushing fluid out, and we have decreased oncotic pressure holding fluid in. So we get edematous. Questions? Are we not following? Some reasons for this. Obviously liver disease, right? Cirrhosis. Cirrhosis, again, is the most common cause, in this case, of liver problems. of ascites. Okay, so the most common cause of ascites related to liver problems is cirrhosis. Other causes we've talked about over the 2 semesters, right, that cause ascites, but we're focusing on liver issues. Ascites is a bad sign. If someone with cirrhosis has ascites, it's usually a pretty big sign of mortality, so impending death, right? People usually, 25% of people with ascites usually die within 1 year of that condition.
What was that number?
25%. So another visual, what we just talked about, portal hypertension versus hepatocyte failure. The portal hypertension with our increased hydrostatic, hepatocyte failure with our decreased oncotic, gives you a little more detail. Showing you more detail about those processes. And then our signs and symptoms of ascites. Weight gain, remember that weight is the best indicator of fluid status, so if you are retaining fluid, you will see weight gain. Now, we just had a few patients in senior med surg. We seem to have a few every year. We had one guy who had gained 40 pounds in fluid because of liver disease and liver failure. So it can be pretty significant. So, and that was over a 2-week period, so imagine that. Trying to carry around 40 extra pounds over, and he was old and not in good health, so not a good thing. Abdominal distension, so abdomen starts to get larger. Increased abdominal girth. Now, I don't know, when I was in school, we had to measure with a tape measure and mark the tape measure. I don't think they do that much anymore. But if you did, you could measure. That just means a larger waist size. Diaphragmatic displacement, especially as levels or fluid amounts approach 10 to 20 liters. So what does that mean?
Does that mean like the fluid buildup in the abdomen so high it's like pushing the diaphragm
Yeah.
up?
It's pushing the diaphragm up. So the diaphragm divides your thoracic and abdominal cavities, right? If there's so much fluid in the abdomen, because that's where it's leaking from, right, the liver's in the abdomen, it starts pushing up on the diaphragm. So that can cause dyspnea, shortness of breath, difficulty breathing. It decreases your lung capacity. It makes your lung field smaller. Your lungs can't expand as well. So what does that increase the risk for? You don't have good, what is it? Pneumonia, infections, right? So respiratory infections, increased respiratory rate. And then there's about 10% of people will have something called bacterial peritonitis, which we talked about last time. And we talked about it in relation to intestinal obstruction. But in this case, a similar process. When you have fluid leaking, and it can leak from not only the bloodstream, but it can leak from the intestines themselves because of this disruption in function, you can have bacteria leak across into the peritoneum and cause an infection there. So bacterial peritonitis includes symptoms like infectious symptoms, fever, chills, and abdominal pain. Does anyone know how we treat ascites in liver disease? Now, most people with ascites have cirrhosis, and we said cirrhosis is irreversible, so we're not fixing the cirrhosis. But we can't let people walk around with 40 extra pounds of fluid on them, right? What can you do?
Diuretics?
You can use diuretics. They do use diuretics. What else? They can put a needle. You should have told me. You should have said it. They can put a needle. It's called a paracentesis. They draw the fluid out. Okay. We've seen this. I've had students where I make sure if they're doing this, if they'll let them in, we go in. They have a special device that the fluid will drain into these big glass containers. Okay, and so they can take liters and liters of fluid out. We don't want to take it out too fast because we can cause, circulatory collapse, but they take several liters out at a time. All right, is that going to fix it? What's going to happen? It's going to happen again. But it provides relief, it provides comfort for the patient. So we do that regularly. All right, this shows you the pathologic process of bacterial peritonitis if you want more detail about that. If you're not understanding what I explained, this will just give you a stepwise procedure. This is showing you ascites. So you can tell this guy is not overweight at all by any means. You can see he's almost cachectic because of these, it looks like muscle wasting here, but really large abdomen. That's all fluid. That kind of looks like my patient years ago. He had a lot of ascites. All right, now hepatorenal syndrome. Hepatorenal syndrome is renal failure because of liver disease. So secondary to liver disease. So it's a secondary renal failure or chronic kidney disease. It can be acute kidney injury as well. So the patho of this, acute kidney injury, is because the disruption in the liver blood flow will cause disruption in other systems' blood flow. So disturbed vascular autoregulation within the kidney. So therefore the kidney is not perfused properly. So we know that's a problem. That's pre-renal acute kidney injury. Because the liver doesn't detoxify the blood properly, we think that some of those toxins will affect the renal system and cause kidney injury. Particularly through disrupting, again, blood flow. So therefore you get either acute or chronic decreased perfusion to the kidney, and that just loops us back to unit 1, right? Acute kidney injury or chronic kidney disease. So you'll see rising levels of creatinine, decreased GFR. So depending on how it takes place, it could be either, I probably should do acute and gradual for acute kidney injury and chronic kidney disease. So you can see a very rapid rise in creatinine or a very slow, prolonged rise in creatinine over time. It depends on the individual. It depends on the severity of their disease. Of course, we know with kidney injury, one of our early signs is oliguria. And then coexisting with signs of liver failure. So essentially what's going on here is what you guys know about kidney injury and what you're learning now about liver failure happening at the same time and being related to each other through this mechanism that we don't fully understand, by the way. Science doesn't fully understand. These are more theoretical reasons for that kidney injury related to liver disease. Okay, so liver failure, jaundice, ascites, GI bleeding. So those are all symptoms of liver disease. Bless you. Bless you. Low blood pressure, and then signs of uremia. Of course, not on here, I did mention increasing creatinine levels and decreasing GFR. All right, I would like to, so I don't want you guys to have to listen to a really, really long lecture. We have about 10 minutes left. My plan was to stop here, but I would like if you would sit here for another 10 minutes to start the specific liver disorders. So again, I can decrease the amount you have to listen to at home. Would that be okay with you? Okay. So let's talk now. So those are your general manifestations of liver issues. Now we're going to talk about specific liver disorders that will connect directly back to all the symptomology we just talked about. All right, we're just going to talk about the disease's progression, causes, etc. themselves. So the first thing we're going to talk about is hepatitis, particularly viral hepatitis. So hopefully you can see, I know there's a lot of blue up here. You can see we have several different categories of viral hepatitis. Most of them have been decreasing over, let's see, the past 15 years or so. But, so this is A and B, still issues, and we'll talk about the patho. And then we have C, okay, hepatitis C, which we're seeing here about 2010, between 2010 and 2012, we're seeing a rapid increase, which is extremely concerning and not a good thing. All right, so that's your epidemiology here. So A and B have been decreasing steadily, although flattening out here at the bottom. And then C was doing fine, and now it's back on the upswing. Now, We'll talk about reasons, but some of the reasons include vaccination availability. We know we have vaccines for A and B, and there's no vaccine for C, but there's also risk behavior involvement as well. So let's talk about the categories. So certain type, now there's alcoholic hepatitis as well, so there's other reasons why you might have hepatitis. But right here we're focused on the specific categories of viral hepatitis. So we have A, which is mainly transmitted through oral fecal route. So contamination of food, contamination of utensils, poor hand washing. So I always tell the story every year. Several years ago, there was a case up in the Fenway area, Boston, a restaurant. There were people getting infected with hepatitis A. They found it was a worker who was not washing his hands. You remember that? Yeah. Pretty gross, right? So, hand washing, gloves. If anyone's making my food with no gloves on, I'm not eating it. No, go away. So, it's all about hygiene. Contaminated shellfish, also. So, eating raw shellfish at the beach, not a good idea. Sounds stupid, right? My dad used to do it when I was a kid. So, it's not, does anyone know people who still do that? Oh, you do? Don't do that. No. So my mom's sitting there on the beach, you're gonna get hepatitis, and you're like, oh my God, I was so mortified. So, the good thing about hepatitis A is that it is self-limiting. You get sick, you get better, usually. There's a low mortality rate. There's a low incidence that it will cause chronic issues. All right, so that's A. There is a vaccine for A. In recent years, they started giving it, so my older one didn't get it when he was born, my younger one did. So it was in that time period. So my older one's almost 13, my younger one's almost 10. All right, so B and C are in red because those are the bad ones, as you can see by the explanation. So B and C are more severe forms of viral hepatitis. They are implicated in chronic liver disease. They're very difficult to treat. They're hard to cure. They are connected to hepatocellular cancer, so an increased risk of cancer, liver cancer, and increased risk of liver failure, permanent liver failure. So those are the ones we're going to focus on. There is a vaccine for B. There is no vaccine for C. Hepatitis D only co-infects with hepatitis B. So hepatitis B must be present for hepatitis D to be able to infect. So is there a vaccine for hepatitis D?
Wait, yeah.
Yes. Right? Why?
There's a hepatitis B vaccine and
Right. So if there's a hepatitis B vaccine and D can only co-infect with B, then that vaccine will cover hepatitis D. Does that make sense? Okay, good. Hepatitis E, you don't see much here. Occurs mostly in Asia and Africa. It is also fecal-oral route from usually contaminated water. It is self-limiting as well. However, it's particularly dangerous to pregnant women. Then we have hepatitis G, which we don't see at all. It is around, it's a newly named category, and then remembering that within a lot of these categories there are subcategories. Viral hepatitis does have more categories than this as well, but I really want to just focus, first of all, you don't need to know all that information, and we really just need to focus on the ones we see most here, if that's okay. If you really want to know about more of them, feel free to look those up. And then we have alcoholic cirrhosis, which starts with alcoholic hepatitis, which is why it's on here. We'll discuss that separately, or I will discuss that separately. All right, risk factors, just for B and C. What are the risk factors for hepatitis B and C? What do you know about hepatitis?
dirty needle usage.
Yep, so IV drug abuse, dirty needles, sexual transmission, any contact with blood or body fluids. So what working group of people is at risk then?
Oh.
Yes, you, healthcare workers, which is why we force you to get the hepatitis B vaccine and tell you to be really careful with universal precautions for hepatitis C. Now, I know in your book, they go into all the different ones and how they all differently evolve, right? Do I want you to memorize all that? No, I don't. We're going to go into some generalities about hepatitis. So knowing, and I don't know if I'll get through this whole slide, I don't think I will, but let's start. Knowing the symptoms range from mild to severe. Actually, you know what? No, because I'm going to go through it all again anyway on the recording. So let's stop there. Any questions? Okay, so I will record the rest of the unit here and have you guys listen to it over the weekend, and then we'll get into some nice connecting type activities so that you understand the broad picture on Monday. Okay? Questions over the weekend, please email me, and have a good one.